Welcome, everyone. We're going to go ahead and get started. My name is Sherri Rose, and I'm an associate professor of health policy here at Stanford. I'm delighted to be hosting Stanford Health Policy's first health equity panel as part of the launch of the new Department of Health Policy in the School of Medicine. This panel also serves as an introduction to a new flagship health equity lecture series at Stanford that will begin in 2022. We look forward to sharing those announcements with you in the future. Stanford Health Policy is a unifying hub for policy research on campus, bringing together the Department of Health Policy and the School of Medicine with the Center for Health Policy and the Freeman Spogli Institute for International Studies. Stanford Health Policy's mission is centered on interdisciplinary innovation, discovery, and education to improve health policy. Our health equity panel today supports this mission, where leaders from multiple disciplines will share their insights on COVID-19, families and health, and Medicaid. While these three themes will be major focal points, we encourage audience questions on health equity that intersect with other areas. This could also include the field of health equity research itself, who is doing this work, who is recognized for it, and how it has been historically funded or rather underfunded. The panel will begin with short remarks from each of our esteemed panelists, introduced by my colleague, Dr. Maya Rossin-Slater, who will then moderate a structured Q&A. Please keep your microphones muted throughout this portion of the panel. We'll then open the virtual floor to audience Q&A, prioritizing questions from trainees. Given the number of attendees, it will be helpful if you type a short version of your question into the chat or send it to me as a message. If you are a trainee, please identify yourself as such. We'll call on as many people as we can to ask their submitted questions verbally. This panel is being recorded and will be posted on the Stanford Health Policy website in the days following the event. With that, I will pass the microphone to Dr. Maya Rossin-Slater.
Great. Thank you so much, Sherri. It's a pleasure to be here, and I'm really excited to introduce each of our panelists. So we'll go ahead and go in alphabetical order, and I'll just say a few words about each speaker, and then I'll let that speaker say their introductory remarks, and then we'll move on to the next person. So we're going to start with Samantha Artega. She's the Vice President and Director of the Racial Equity and Health Policy Program at the Kaiser Family Foundation. Her work focuses on the intersection of racism and discrimination, social and economic inequities, and health. She also has conducted extensive work related to the health and healthcare needs of low-income populations and immigrant families, and previously served as Associate Director of KFF's program on Medicaid and the uninsured. Samantha, we're delighted to have you, and please go ahead.
Thank you. It's really an honor to be included in today's panel discussion. So thanks so much for having me. I am going to share just a few slides to accompany my remarks today. So just bear with me as I get those going. Can everyone see those okay? Great.
Yes.
Perfect. So what I wanted to do is really just start out by talking about some of the main issues that are top of mind for me today as we're thinking about health equity related to COVID-19, as well as more broadly. And I think we on this call certainly all know that one of the most widely recognized aspects of the COVID-19 pandemic is how uneven its impacts have been. We know that people of color, lower income people, and other historically underserved groups have really borne the brunt of the pandemic. And this is not only in terms of direct health impacts as measured by cases, hospitalizations, and deaths as seen here, but also in terms of broader social and economic impacts. We also know that the pandemic has significantly increased awareness and attention to disparities. Many people who maybe were not previously focused on these issues have a new awareness. There's also been growing calls to address disparities and advance health equity that has been driven by the disparities exposed by the pandemic. But for those of us working in the field of health equity, none of the pandemic's disproportionate impacts were surprising or new. The pandemic really just exposed and exploited inequities that have been baked into our system for decades. Before the pandemic, we know that people of color fared worse across a broad range of health outcome measures, as well as measures of healthcare access, use, and quality. And these disparities have been recognized and documented for decades leading up to the pandemic. And we also know that these disparities in health and healthcare are driven by a broad array of social and economic factors that sit outside our healthcare system and that are rooted in racism and discrimination. So given where we are today, both as it relates to the disparities created by COVID-19, as well as the disparities that existed long before the pandemic, I really think there are a broad range of priorities for work looking ahead. Mitigating the disproportionate impacts of COVID is going to be key for preventing against even further widening of the disparities that existed before the pandemic. I also think that we have to focus on how we maintain attention and resources focused on health equity over the long term, so that this momentum and focus on advancing health equity is sustained and it does not become a passing trend. Along with that, we have to think about how we move beyond just prioritization of health equity to putting the resources behind that prioritization. How can we direct resources to health equity, both within the healthcare system, but across the other sectors that we know drive health outcomes? I also think it's important that we name and recognize racism as a cause of these disparities in health and healthcare. And in addition, we really need to think about how we can elevate the role of communities in our action to address health disparities and to make sure that a community is involved from the outset of efforts to design initiatives to advance equity and address disparities. And last, I'll close on an issue that I have been extremely highly focused on over the course of the pandemic and continuing on today is really the ongoing gaps we have in data to identify and address disparities. So this is a problem that existed before the pandemic, but again, has been revealed by the pandemic. And I think here we are seeing the consequences of just long-term lack of prioritization of data to identify and address disparities. So now nearly 2 years into the pandemic, we still lack key data to both identify the disparate impacts of COVID-19, as well as to fully understand disparities in COVID-19 vaccination uptake. And we really need to get serious about improving the data that are available to identify and address disparities, because we simply cannot address what we cannot see. And so I'll stop there and really look forward to the conversation today. Thank you.
Thank you so much. Okay, up next, we have Kirstin Bibbins-Domingo, who is a professor and chair of the Department of Epidemiology and Biostatistics and the Lee Goldman MD Endowed Professor of Medicine at UC San Francisco. She serves as the inaugural Vice Dean for Population Health and Health Equity in the UCSF School of Medicine. Dr. Bibbins-Domingo co-founded the UCSF Center for Vulnerable Populations at Zuckerberg San Francisco General Hospital that generates actionable research to increase health equity and reduce health disparities in at-risk populations in the San Francisco Bay Area and nationally. She also leads the UCSF Cardiovascular Disease Policy Model Group that conducts simulation modeling, disease projections, and cost-effectiveness analyses related to cardiovascular disease in the US and in other national contexts. I think you're muted.
Thanks so much for having me, and congratulations on the launch of this panel. I'm going to use slides also. I don't know why there we go. And really appreciated Samantha setting the context here. When I reflected on the topic that we're addressing here today, I was reminded of what we were doing the year before the pandemic, or what I was doing the year before the pandemic. And I had the good fortune of leading this National Academies Committee on integrating social care into the delivery of healthcare, recognizing that after decades of research saying that social context matters to health, in fact, healthcare is probably a much smaller contributor to overall individual and population health, that there was a concerted effort to think about how we might think about social care in the context of healthcare delivery. This report was released at the end of 2019 and had 3 major recommendations that came out of it. The importance of people in doing this work, the types of adequately staffed and well-trained workforce to do this work, the importance of digital infrastructure, of data and of data integration, and that really we needed new models for financing that align our resources with our goals that we might have. This committee was focused on social care, which isn't necessarily completely synonymous with the issues related to health equity and health disparities. In fact, all of us at different points in our lives, when we're ill, might have particular social needs that are important to be addressed in the healthcare setting. But certainly individuals and communities that have been historically disadvantaged, that have been marginalized, that suffer from the most upstream issues of poverty, racism, structural inequalities, have the social needs are greater and disproportionately affect the health outcomes. The pandemic was, of course, a stress test, and as Samantha said, really wasn't a surprise to those of us in this field for a long time, but certainly raised the awareness for everyone else. I think for me, I'll show two aspects of our work in this area, and a way to think about the health inequities during the pandemic, and my insights and our group's insights as a result of some of these. So these are looking at deaths in California, excess deaths compared to the prior years. We're looking at death certificate deaths, and here showing that basically the excess mortality stratified by educational level. And in fact, 2/3 of the excess mortality during the pandemic time in California has been in people who have no more than a high school education. 2/3. That's been fairly consistent throughout. Now, you will all know, of course, that whether you follow Professor Kaiser and Deaton and diseases of despair, we know that educational disadvantage is associated with poor health outcomes. But to see this striking and throughout the entire pandemic and the large numbers, 2/3, has really been quite remarkable. Professor Case and Deaton say that this isn't greater than one might anticipate, and it hasn't gotten worse over time, but it also hasn't gotten better over time. Education is, of course, related to job opportunities. It's related to income. It's related to agency within particular jobs that might have associated benefits that allow one to protect oneself. And the other thing that we've been doing is to really highlight the types of excess mortality associated with classes of types of jobs and sectors of essential work. So while Latinos have a disproportionately higher excess mortality during the pandemic, those who are working in food and agriculture have really strikingly higher mortality. These aspects, education and occupation, are variables that we oftentimes don't think about when we capture health data or think about in the design of our interventions. And I think what wasn't clear during the pandemic for me was not just that these inequities were going to happen, but since virus circulating anywhere really is a risk to all of us everywhere, the sort of lack of awareness that an equitable response in the pandemic is not just a nice thing to have, but is a need thing to have if we're going to actually have an effective pandemic response. And so it's making that leap that I think has really been, reminds me how important it is to keep equity on the front burner and not to assume people are going to get how important this is to actually just our overall goals of effectiveness. California, I think, does deserve a lot of credit for thinking about equity and actually baking in some metrics. These are health equity metrics that were incorporated into some of the reopening early on, and I think sort of reminded us that we do need to call out the health equity issues and bake them into our milestones and our pandemic response. You saw this as well in how we thought about vaccine rollout, not always entirely effectively, but I think a focus on not just thinking about age, but also thinking about those communities that were most at risk for poor outcomes during the pandemic and focusing on our vaccination rollouts there. Others on the panel, and we have been looking at what we learned from doing different approaches, not just understanding age as a risk factor, but recognizing that often the communities we're talking about have a pattern that skews younger in terms of vulnerability and the outcomes, and that recognizing this, that age, in fact, is one of those things that a policy that actually then disadvantages the communities that have been disproportionately affected by the worst outcomes here, and thinking about how geographically, our geographic understanding of areas of vulnerability can in fact sometimes lead to more equitable responses. So just from my reflections, equity doesn't just happen without an explicit focus. Inequities are either preserved or worsened. That's true time and time again. Data is critical, as Samantha said already. When it comes to health interventions that consider social context, it is not just collection of data, but it is also integration of data across multiple sectors. And then, as with most things in healthcare, if we're going to achieve our goals, you need metrics and accountability. Accountability that's both regulatory and financial levers to do this. And if we're going to make a change and be serious about this, those things will need to be in place. I'll stop.
Thank you so much. Okay, up next we have Sherri Goldhaber-Fieber, who's a professor of health policy in our Department of Health Policy at Stanford School of Medicine. His research focuses on complex policy decisions surrounding the prevention and management of increasingly common chronic diseases and the life course impact of exposure to their risk factors. Most recently, he has led multiple research studies about the COVID-19 pandemic, studying disease spread and vaccination effectiveness in the California imprisoned population, as well as inequities in both disease spread and vaccination uptake across socioeconomic and racial and ethnic groups. He has been regularly advising local, state, and national policy leaders on key decisions during the pandemic. Thank you.
Hi, thank you. So I think some of the things that I will mention will connect to, and I hope sort of add to what has been already raised. I want to sort of talk about the fact that the panel that we're talking about is about equity, but in order to sort of think about approaches to achieving equity, we have to think about the details of the differences and disparities that exist and persist. And so I want to sort of talk about two themes within the context of those existing disparities. One is the theme of concentration, and the other one is the theme of intersection. So what do I mean by concentration? So as a set of stylized facts, people of color are more likely to be poor in the US, more likely to live in households with fewer rooms than people, more likely to live in a household where they or a household member is engaged in an essential job that requires being in person, and more likely to live in multi-generational households. And importantly, to live in neighborhoods with other people who are POC and people of color, and in where those similar households exist. So in some sense, location or neighborhood or small area concentrate to the extent that these things are risks for COVID-19 or for other respiratory infections. These kind of neighborhoods concentrate risks on households, which concentrate risks on individuals. And that's important to recognize. And that's one sort of way, kind of, I think of kind of connecting between the individual and sort of the community level. In California, we also see that people of color are incarcerated in rates greatly exceeding their population fraction. For example, the Black population in California is roughly 5%, and in prisons, they're represented as at a 4-to-1 ratio, more or less. So greatly overrepresented. And to the extent that prisons and jails have case rates that are 5 times or greater than the general population, and people flow to and from communities, that's another way where risk is sort of translated from one setting to another, and differentially so for the people who are exposed to those settings disproportionately. Okay. So I think a challenge that kind of comes out of that first piece about concentration is really how to think about analyses that are neither ecological, only looking at areas, nor individual, that look at individual risk factors and don't consider the context, in a way that is very convincing and also that provides actionable and useful insights. And I think that
You're on
Jeremy, I think you went on mute.
Sorry about that. The other thing I want to talk about is intersection. So what do I mean by intersection? So matching people based on age and sex and living in the same relatively small geographic area or areas coded by their level of social vulnerability or poverty, we see that the rates of death are higher in people of color than non-Hispanic whites who live in the same areas, right? And that's consistent. We certainly see that across California and in other places that's been documented. So you could ask the question, so why? And there are a number of plausible explanations. I want to sort of focus on two that both have to deal with this notion of intersection. So this is an intersection of the risk posed by infection and disease, COVID-19, overlapping with the concentration existing of conditions that predispose to bad outcomes conditional upon being infected, right? And the fact that people of color often have higher prevalences of conditions that predispose them to having worse outcomes. So that's one sort of form of intersection. The other form of intersection is that this intersection between those risks posed to you by COVIDs particularly, and particular challenges in accessing and trusting the services that might be available, whether they be language barriers or socioeconomic barriers in terms of time off work or cost of accessing those services. So one way that we can think about this specifically in the context of COVID, and this is the last point, and then I'll stop my kind of remarks, is if you imagine in a particular area, parents with kids who, one group who are POC and the other group who are non-Hispanic whites, and let's say 40% of those two sets of parents, both groups, are equally enthusiastic about vaccinating their kids. And we've actually looked at this in counties in California. What we see is within the first couple of weeks, let's say roughly 20% of the non-Hispanic white group have vaccinated their children, right? Whereas 5 to 10% of the Black and Hispanic parents have vaccinated their children. And it's hard to say, oh, this is just a difference in sort of enthusiasm for vaccine, because we know that a larger proportion than that 20% or 10% or 5% are vaccine enthusiastic, or at least have said they're vaccine enthusiastic. So it must be that there are some set of barriers to acting quickly to protect your kids that are differentially acting on one group versus another. And thinking about the intersection of those barriers, those more general access barriers and challenges, is really important in terms of thinking about service design. So again, concentration and intersection, I think, are going to be important, and this sort of multi-level approach is going to be important in terms of thinking about how we design better approaches to achieving equity.
Thank you, Jeremy. And then last but not least, we have Petra Pearson, who's an assistant professor of economics here at Stanford. She's also a faculty fellow at the Stanford Institute for Economic Policy Research, a faculty research fellow at the National Bureau of Economic Research, and a research affiliate at the Center for Economic Policy Research. Her research examines the roles of family structure and public policies in propagating or reducing population-level health disparities. She uses quasi-experimental research designs on large-scale administrative data sets from the US and Sweden to produce causal estimates that are critical to inform decisions of policymakers and other stakeholders.
Thank you so much for that introduction, and it's a great pleasure to be here. So I'm a health economist, and my work on health equity centers around the role of families. So I study how factors like family background and family behaviors generate and sustain health inequality. So let me give you one example, and this is about the HPV vaccine. Very soon we'll be able to draw this with the COVID vaccine as well. So it's well known that a child's family background is predictive of health outcomes, but less is known about the underlying causal mechanisms. Now, this figure plots the share of young women and girls that have received the HPV vaccine against their parents' income rank at birth. So we see that children born into a family at the top of the income distribution is about 4 times as likely to have received the vaccine 20 years later than a child born into the lowest end of the income spectrum. To draw this relationship with such granular income information, we use administrative tax records for the entire population of Sweden. And because Sweden has universal health insurance, all health records are in one place, so we can link these tax records to health records. One striking aspect of studying health inequality in Sweden is that everyone here has access to essentially free healthcare. So this figure tells us that even in a setting where we shut down any differences across the socioeconomic spectrum in health insurance coverage or affordability, a strong socioeconomic gradient persists. Now let's look at the same graph, but separately for girls who have a doctor or nurse in the family, that's the red triangles, and for girls who don't have any family member who's a nurse or doctor, that's the blue squares. Here, we exploit the fact that in these Swedish data, we can link these girls to their parents, aunts, uncles, and siblings. We see that the income gradient persists, but at all points in the income distribution, girls who have a family member with medical knowledge tend to have higher vaccine take-up. This suggests that families may serve as a nexus of informal transmission of health-related information that is essential for preventive health. Now, all I'm showing you here is a correlation, but in this work, we go on to exploit a peculiar feature of the Swedish context, namely that admission to medical school is sometimes determined by lottery. So this allows us to investigate whether there's a causal relationship. And indeed, our results show that individuals who have a family member with health-related information make substantially higher preventive health investments. They're more likely to get vaccinated. They're less likely to smoke in pregnancy. And in older adulthood, if we look at other relatives, they are more likely to adhere to statins, for example. This relates crucially to health equity because health-related knowledge is distributed highly unevenly in society. We see this among medical professionals, so individuals from high-income backgrounds are more likely to become medical doctors, and even nurses who tend to come from more mixed backgrounds are not typically drawn from the lower tail of the income distribution. And beyond medical professionals, all available measures of health literacy that we have suggest that there is less of it at the lower end of the socioeconomic spectrum. So not everyone in society has an equal chance to rely on health-related knowledge that we know is so important for preventive health. Policies that strive to promote diversity in the medical profession would help equal the playing field, as this could generate informal information sharing within families also at the lower end of the income spectrum, which in turn might provoke more equal preventive health investments. Now, in light of this policy implication, it's a little saddening to see that if anything, the medical profession, at least in the context we're studying, is in reality becoming less diverse over time. So this figure shows the share of medical school graduates in Sweden who have parents who are also doctors. And we see that over the last 40 years, from 1950 to 1990, this share has risen fourfold from 5% to 20%. So medical knowledge is becoming concentrated into fewer and fewer families rather than the opposite. So this suggests that we have a lot of work to do in reversing this. Thank you so much.
Wonderful. Thank you so much, Petra. So now we're going to move on to the moderated Q&A portion of our panel. We have prepared some questions for our panelists. So several of these questions, I think, any one of you is welcome to, provide your thoughts on. Some of them are more specific to certain panelists. So we'll go ahead and do that for about the next half hour, and then we'll move on to some audience Q&A for the last 15 minutes of this panel. Great. Okay, so let me start with, since several of you talked about COVID, of course, during your remarks, let's start by talking a little bit more about COVID and specifically maybe like what to do going forward. So this question is about that. Like, given what we know about the inequities and the impacts of COVID on families with kids, both in terms of the virus infection and death rates and all of these things, but also differences in impacts of remote learning for kids, differences in economic effects, so other aspects of the pandemic. What do you think are some of the policies that should be first priorities to reduce inequities going forward? Like, would you or do you suggest to state and federal legislators on this front? So I'll open it up to any panelists who want to speak on that. Jeremy?
Well, obviously, it's been in the news recently about the approval of the EUA, the emergency use authorization for vaccination for younger kids. And to the extent that different people face different barriers in terms of getting one's kids vaccinated, in terms of the costs and the time off work, supporting people's ability to get vaccination for their kids should have a differential effect and should improve equity.
Anyone else?
Yeah, so I can also, I think we know that the pandemic, just to mention one other aspect, so we know that the pandemic widened the academic gap between kids from advantaged and disadvantaged backgrounds. Remote learning seems to work poorly for the most vulnerable children in society. And further, closing schools has an impact on nutrition for children who rely on free lunch programs. So this suggests that any policies that can help keep schools open safely should be a high priority on the part of policymakers. Now, there are, of course, a wide range of policies that matter here, and many are determined at the school district level. But one important example, I think, of something that happens at the upper levels are these mask mandate prohibitions that are adopted by several states. So if parents are reluctant to send their children to school, if other kids are not masked, then removing schools' ability to ask children to be masked may be counterproductive.
I think I would just note that, just in my comments, as we noted that health is driven by so many factors that are broader than the healthcare system and how we access healthcare, that as we're thinking about responding and recovering from the pandemic and mitigating its disproportionate impacts, that we're thinking broadly across those sectors and really all the wide-ranging ways that children and families have been affected. Again, education is one. Even just in terms of grief and loss, there was a really profound article published in Pediatrics just last month that showed children of color were more likely to have lost a parent or a caregiver due to COVID-19 compared to their white counterparts. So as we're thinking about an equitable response to the pandemic, we really need to be thinking broadly in terms of how children and families have been impacted well beyond the direct health impacts of the virus itself.
Yeah, and just to underscore what some of the points that were just made, let's just remember, in California, if you were in public schools, you mostly did not go to school in person all of last year. If your child was in a private school, they went to school for the most part, as far as I can tell. So right there, we can see what's happened in California. That puts an urgency on in-person learning in California as should be the policy norm for this year. It will be one of those that we will continue to debate back and forth on, like, how much can we ease up on some of the measures that seem to be inconvenient? How much can we push on other things? And I think because in-person learning is it is going to be such an important anchor on how we're going to have an equitable response for families for a whole variety of reasons that others mentioned. Ensuring that we can do that safely then becomes the means to that end of everyone being there. We will have all of the debates on, couldn't we ease up on this? And we will also need to recognize that that for many of our poorest, most marginalized communities, the experience of the pandemic itself is not one that has engendered trust in other types of government action related to safety. And so I think we sometimes think that it's so obvious in-person learning, we should just do that. That requires commitment, it requires resources, and it requires lots of on-the-ground engagement as well in order to make this work. I would like to see a lot of our vaccination efforts in this regard really be around sort of communities and schools. Again, that's what I would have liked to see from the beginning, because I do think the issues of trust are real, and because the experience during the pandemic has been wildly different. And I think that the only way to heal some of that trust is to think about our community resources, and to think about any given intervention like vaccination for 5 to 11-year-olds as something that communities do in order to sort of get back to the types of health that we all hope we can get to.
Thank you. That's really, really helpful to hear from all of you. So I guess building off of that, I think there's lots of things I think we've learned during COVID, but if you had to come up with one lesson that we take away as we, inevitably have to prepare for whenever the next pandemic is, what is the key lesson that we should bring with us, especially with regards to health equity?
There are so many lessons, but if we're going to choose one just to focus on, I'll come back to the data issues. And I know it sounds like somewhat of a dry topic, but really, I think if you think back to the beginning of the pandemic, we didn't even have data to understand racial disparities in impacts in terms of infections and deaths. Most states were not reporting those measures by race and ethnicity. The federal government was not initially reporting those measures broken out by race and ethnicity. When the vaccination rollout started, we saw that there was more reporting by race and ethnicity, but to this day, CDC is still not reporting state level data on vaccinations by race and ethnicity. We don't have data available to cross-cut vaccinations by race, ethnicity, and age. So as the kids become eligible, we're not going to have any way to know if there are racial disparities in uptake of the vaccination among kids without changes in the reporting. My team spends an inordinate amount of time collecting and analyzing data that are reported from the states on vaccinations by race and ethnicity. And it is a very challenging task because there is no consistency in how states report their data. They are all over the place in racial ethnic classifications, in the units of measure that they use to report, in the time periods of their reporting. And again, I come back to this issue that if we really want to effectively understand where there are problems and address them, then we need data to help guide those efforts. And it needs to be comprehensive, high quality data that is disaggregated down to the levels of people and groups that we care about. And without that data, we are always going to be missing part of the picture. And we also lack the ability to measure progress and build in accountability to systems for achieving equity going forward.
Jeremy?
So I agree with what Samantha said, and I would just add to that I think what we've seen is when responses are designed without explicitly thinking about equity, they recapitulate inequity. And so in order to design, so you have to design them thinking about equity and likely pathways that inequity is produced by those policies. And then you need the data so that you can have metrics to track whether that actually is what occurs, and how are you doing part of that as well.
Okay, thank you. Okay, we're going to move on from COVID a little bit and talk about other aspects of health equity. So now actually I have a question, I guess, specifically for Petra based on her research. What do you think we learn about health inequality by comparing data between, countries like the United States, as well as countries like Sweden, where a lot of your work has been set? What are some lessons that we can draw about that?
Yeah, thank you for this question. So I think when we think broadly about health inequality, there are many drivers of health inequality, health inequities, and we've mentioned several of them here together. And I know later in this panel we're going to talk about Medicaid and explicitly think about what is the role of access to health insurance in all of this. So there's a broad range of potential causes of health inequality. And one of the interesting things with studying health inequality in Sweden or in other countries that have universal health insurance is that we can think of that as a context where, it's essentially like a lab where we are able to shut down one of the often hypothesized drivers of health inequality, namely differences across the socioeconomic spectrum in access to health insurance or in quality of health insurance. So by going to countries where, everyone has exactly the same insurance product, essentially a public insurance product across the income distribution, we are in a world where we know that differences in health insurance are not likely to be generating the health inequality that we still see. And then Sweden in particular is also a place, that generally is less unequal in many ways than, say, the United States. Education is free and so forth. So we're shutting down, probably even more mechanisms that people think are important in generating health inequality than just differences in access to health insurance. So that makes it interesting to compare health inequality in Sweden and the US, for example.
Thank you. I see that there's a couple questions, I think, from the audience about more things related to Sweden, but we'll get to those a little bit later on. Let me actually move on and talk a bit about Medicaid specifically, as that is an important aspect of the US health infrastructure system and with regards to health equity. Just to get in the weeds just a little bit, there's a lot of discussion about how to best structure payment within Medicaid, fee for service versus managed care systems, capitation payment models. How do we think about the trade-offs in those two systems, especially as they relate to health equity? And what do you think would be, the optimal policy in terms of administering a program like Medicaid from the perspective of health equity?
Well, I'll jump in. So I think that that we have to again incentivize the types of things that we want to achieve, and I think that is one of the issues that we in the Academies Committee we're wrestling with, is how to align our payment models to actually reinforce what we want to achieve. If we recognize that for everyone, healthcare is only a small contributor to overall health, and for more marginalized, vulnerable individuals, populations, the contribution of the social context to poor health is likely to be even greater than for a system like Medicaid. We have to align those systems to actually incentivize what we want to achieve. So I take care of patients at San Francisco General Hospital. During the pandemic, all of a sudden the awareness that my patients who don't have housing was going to make it difficult to actually get them to isolate and quarantine, which was all of a sudden a public health mandate, all of a sudden led to lots of rethinking about what housing means for health in a very positive way. And I think going forward, what we cannot do is to lose that tie, right? It's complicated to do that. And I think that there are many models for how to do that. We cannot do housing in healthcare all the time, right? Because we don't know how to do housing. We're really bad at even doing like things like electronic health records. So like doing housing on top of that is hard. Other social service agencies that do address a lot of social needs oftentimes are not actually able to contracting other types of things that have made it difficult for them to participate in the way that we typically do reimbursements for healthcare. So it's a complex landscape, but it does need to be one that aligns our financial models to allow us to think a little bit more creatively and differently about how to address these needs. I think there have been some models during the pandemic generated out of need, and my hope is that the payers, particularly like Medicaid, will continue both to to fund sort of potential more innovative models, as well as think of those that work and sustain them over time, because that's what we're going to need to start building on.
And I'll just jump in. I don't know that I can come in and say which model is most appropriate. I think where we are today is 2/3 of Medicaid beneficiaries are in a managed care arrangement, and that it's largely families and children that are in these managed care arrangements within Medicaid. I think, as was just mentioned, there are a series of incentives that are built into the payment model as a capitated payment that create incentives to contain costs. But at the same time, I think we are seeing that states are really leveraging the managed care model as a way for them to better address social determinants of health, as was just mentioned, and build in incentives and in some cases standards for providers to meet health equity goals. Or the states are building in these incentives and arrangements for the managed care plans. So for example, we see states using contracting requirements with managed care plans to establish standards related to screening for social needs, related to connecting beneficiaries with identified social needs to those services in the community. So those are the types of work we're seeing. We're also seeing some states requiring managed care plans to contract with community health workers as part of their provider networks. So there are a range of ways that I think states are trying to leverage the model to better get at some of these factors that sit slightly outside of the healthcare system without creeping the scope too much, because healthcare can't do anything, but how can we better connect to the social service providers that already exist? And then we also know that Medicaid funds cannot be used to directly pay for non-medical services, but there are some flexibilities that can allow for some payment for these non-medical services in very weedy ways in terms of value-added services. You quickly get really deep into the weeds on reimbursement, but just to say, I think there are ways states can leverage that model to address social needs and do more work on health equity, but it needs to be balanced against the broader incentives that are built within the capitated model system.
Thank you. Jeremy, I thought I saw you raise your hand.
I had just a small one, which was to the extent that providers and healthcare delivery sites and organizations can opt out of accepting Medicaid or Medi-Cal patients, that creates inequities. And so one can think about different payment models, but if one of the drivers of not accepting those patients is the level of payment, regardless of whether you're paying capitated or fee for service, that's a problem. And so addressing the ability of people to access desirable and convenient providers, I think is probably part of an effective approach.
Thanks. That was actually going to be my next question, which was about, we know that Medicaid covers a huge share of the population, especially when we talk about kids, right? Something like almost half of all births in the United States are covered by Medicaid. And yet there's this big challenge with that. A lot of providers don't accept Medicaid patients. And how do we think about that in the context of reducing inequity, especially in early life and going forward? But then let me incorporate that question into my other question about Medicaid, which is just more generally, the evidence on the impact of, say, expansions of Medicaid, whether looking back, in the 1990s or, through the ACA more recent years, the evidence on the impacts of the expansions of Medicaid on health outcomes has been mixed. So some studies find effects, others do not find large effects. And so I'm curious what you take from that evidence, and how do we think about the best way to implement this big program, again, from the perspective of reducing health inequities.
I can start. I mean, we know from the research literature, and we have an amazing literature review conducted by our Medicaid team over at KFF of hundreds of studies on the impact of Medicaid expansion. And my team has done some pulled out analysis, really looking at the studies that focus on racial health disparities and the impacts of Medicaid expansion. We know that expansion has helped to reduce a lot of the racial disparities in coverage and access to care. That's a pretty consistent finding across the studies. As you note, there is more mixed evidence in terms of health outcomes. And I think we can point to a range of factors there. You know, in some cases, the studies find narrowed racial disparities for some groups, but not others. So there's variation in what we see in terms of how different groups have been impacted. In some cases, we see that all groups experienced improvements in a measure, but that the disparities between groups didn't necessarily narrow. So that's another way that we're seeing some of those findings play out. And then I think what we're seeing at play is, again, the fact that there are the factors that sit outside the healthcare system play such a pivotal role in driving what health outcomes are. So yes, coverage is a key essential piece of this puzzle, but if we're not also addressing those broader social and economic factors that, as was shown earlier, play an even larger role in shaping our health outcomes, it's much harder to move the needle on those measures. I think also you need a long time horizon to see changes in health outcomes compared to seeing changes in measures of coverage and access, which will appear much more quickly in terms of the data. So I'll stop there.
Yeah, I think this is slightly off topic, but Samantha's come and just reminded me of that. You see that also in lots of great studies that look at, screening for social needs has become all the rage. But if you look at the interventions that focus in the healthcare setting on what is done, then they oftentimes are also variable because the larger social context in which people live is actually creates its own challenges apart from just I made the referral so that somebody can go get food if they're food insecure, or I provided transportation to get to healthcare. Healthcare is essential, but the larger factors and that exist and shape health, healthcare will always be somewhat limited in its ability to make to make changes in the broader context. That's why, for me, I think we have to, though, think about things in the broader context, not say that this is a failure of expansion, because I think because access to healthcare is critical, particularly for the most vulnerable, but rather think about how healthcare as a sector contributes outside of the healthcare sector to the factors that shape health. For some, it will be providing access to Medi-Cal patients, Medicaid patients. For others, it will be actually using the other things that healthcare sectors do, like their community benefits, like their other advocacy and other philanthropic dollars to actually influence the factors that shape health. And I think we cannot just say, well, that really didn't work, so we can't do anything. I think we have to say access is critical. This is one lever to increase access to our most vulnerable communities, and then we have to do more.
Thank you. Okay, I'm going to ask one final question, then we'll turn to the audience Q&A. And this question is for all of you. And that is, what do you think are the top priorities for the field of health equity? And how, given that we have an interdisciplinary panel, how do you think different fields can best contribute to this research? So maybe we'll go, if it's okay, we'll go in reverse alphabetical order this time. So we'll start with Petra and then go to Jeremy, Kirstin, and Samantha.
Thank you. So I guess my focus on families with children let me mention a few public policies that target families with children that are important, I think, in reducing health inequities. So we have right now we've heard a lot of discussion about parental leave policies. So we know that 12 weeks of maternity leave has important benefit for a range of outcomes, including child health. Today, when many women do not have access to paid family leave, the ability to take such leave is a matter of resources. So policies that actually provide paid leave would allow low-income mothers to take time off with their children during the first important time after birth. We also know that there are important policies like WIC is important in the United States. We have some evidence from other countries that allowing fathers to take parental leave shortly after childbirth improves maternal postpartum health. So again, providing families with the ability to tap into such policies. And finally, if we talk about families with children, I want to emphasize that it's important to also think about the prenatal period. So policies that make pregnancy less stressful, and many of these are the kinds of policies that generally help smooth life for vulnerable populations, like unemployment insurance, for example. But we can also think about policies that are specific to targeting women who are pregnant. And I guess in terms of, what are the ways that different disciplines can contribute, I think the issue of health inequity is something that, transcends disciplines. It's not an issue that only economists should be thinking about or only epidemiologists should be thinking about. We've been hearing, multiple perspectives during this panel. There are so many facets of this issue. So it seems extremely natural that we sort of all collaborate in thinking about the solutions together and bring different perspectives to the table here to try to address this issue. Thank you.
I think I'm next, is that right, Maya? Okay. So I'll mention two things. One is, I think that ensuring that the quality of education provided is as high as possible, and that the sort of links between primary and secondary education and higher education are made as robust as possible is very important for equity generally and for health equity in particular. In terms of, I think part of the question also was just about what different disciplines can do or can kind of contribute. So from my perspective, the field of health equity has gotten a boost of attention because of the pandemic. And one thing that I think is really important, as it's invited other researchers from a broad variety of disciplines in, is to ensure that the ways in which the topic is approached are not sort of, of the 80s and 90s, or a kind of capitulating overly simplistic views, throw race, ethnicity on one side of a regression and get a number out and say this is something, but thinking in a much more sophisticated way about these challenges. And so I think a very important contribution would be to ensure that as new members are invited into the fraternity and sorority of health equity research, that those sort of standards and sophistication are maintained.
Really great comments. I like hearing all these other ones. I just want to yes, I agree with that. So I guess I would put a plug in for things for just really underscoring the issues of poverty, the importance of things like universal basic income and people having protections in their workplaces for paid leave, for job security. I think over time and time again, I think we are missing just how deep the divides are along the socioeconomic lines, and those are particularly true for children. Just to sort of highlight those, and how in the experiments that have been done, how much people who have money invest in health, especially for families. I would also say that as we focused a lot on social factors and social context for health, the thing I would not want anyone to leave out is that there are deep healthcare inequities, that once you enter into a healthcare setting, people do not have equal outcomes. And I do worry, I worry as a physician, as somebody who studies disparities, that while the social context is incredibly important for all the reasons we mentioned, it should never let a healthcare system, a payer, a healthcare organization off the hook, because once someone enters the door, they have a responsibility to ensure equitable outcomes. And I think that is something that I worry will get lost. And then I think that this requires, all disciplines to focus on this and to think collaboratively and creatively about doing this. And we probably don't do ourselves a service by sectoring off into our different disciplines, but the hope that we could do this together, I think that's where the solutions will come.
I'll be quick because I know you want to get to questions. So I'll just make a few comments. The first is, I think really, how can we make equity kind of the first consideration or first priority instead of sort of an afterthought at the end of decision making, right? So how do we build in equity to the front end of decision making? And I think that's something that applies across sectors. I think similarly, and this again applies across sectors, how can we shift power to communities, right? So how can we engage communities and give power to communities in telling us what the problems are and then taking the lead in designing and implementing the efforts to address them? And then I will sound like a broken record, but I will come back to the data issue. And here I will highlight the need to also just recognize the increasing diversity of the population, the growing numbers and shares of people that identify as multiracial and multi-ethnic, the growing importance of understanding diversity of experiences within the broader racial ethnic categories, instead of just using these large categories that lump people with very diverse experiences under one heading, and that we really need to be thinking carefully and strategically about how we design data and systems in a way that accurately reflects the diversity of our population today.
Thank you so much. I'm going to turn it over to Sherri now to do the audience Q&A.
Thank you, Maya, and thank you, panelists, for this wonderful discussion. So we are going to turn it to audience Q&A now. We have a number of questions. We won't be able to get to all of them, so thank you, everyone, for your patience. The first question, I'm going to ask Kaylin Purdy to go ahead and ask her question. She's a master's student here at Stanford Health Policy.
Okay, thank you. So my question isn't really for one panelist particularly, but what I'm curious about is actually the effect of basic income. So we know from other countries that do have universal health insurance and perhaps better equity between financial access to healthcare, still have, like we see in Sweden, pretty big gaps in health outcomes. So I'm curious to know what you think about universal basic income and reducing not only socioeconomic status inequities, but also health inequities.
So I'm happy to go first and share some thoughts on this. So I think it's important to emphasize that even though, as I showed you in this graph, there's substantial health inequality in Sweden, what maybe I forgot to emphasize is that if we actually compare this to the United States, across a range of measures, health inequality is lower in Sweden than in the United States. Now, it's actually not that easy to draw, the graphs that I showed you where we have, population level, income information on the x-axis and some health measure on the y-axis. We can't really draw those for the US because in the US, we don't have, all health insurance claims in one place. And even if we did, it's not clear we could link them to tax records. But, there are some health outcomes where we can do this. Mortality, for example, we can link death records to tax records. Professor Chetty et al. Has done that. And if we compare the mortality gradient in Sweden with the mortality gradient in the US, it's interesting. It's equally sharp in Sweden and the US when we look at the really elderly population. But when we look at mortality earlier in life, then it's much less sharp in Sweden. Now, this doesn't suggest that it's because of Sweden's, very substantial social insurance system. It's certainly consistent with that. So it's perfectly plausible that, a very generous social insurance system in general is, translating into health benefits.
Yeah, I guess I would just say that that gradients whether it's by income or education, are observed in a variety of contexts. So it is pretty clear that enhanced investments in the social sector or the social safety net isn't necessarily going, or universal access to healthcare doesn't magically get rid of the gradients. But I think there are very few contexts where you have the enormous expenditure in the healthcare sector like we do in the US, with the outcomes that, whether you want to look at that by the overall aggregate outcomes or the gradient in disparities in outcomes that exist. That is a phenomenon that is really accentuated in the US. And I think we do have to ask whether some attention to the social context and those factors that shape health wouldn't help us to both improve our health outcomes overall, as well as make a gradient that is not as distinctly sharp as it is in the US.
Thank you. So the next question I'd like to turn to is from Christine Oldini. If you wanted to turn on your microphone and your video if you'd like to, and ask your question about funding. I see that Christina is still in the session, but she may not be able to turn on her microphone. So I'll go ahead and pose the question that she asked. Please discuss NIH funding disparities that exist for research focused on women and those who identify as women.
So funding for studies on women, is that the question? Study focused on
research on women.
Yeah, so I'm currently chairing a National Academies group focused on sort of the representation both in our research portfolio overall and within different specific clinical and population and translational studies of women and groups that are traditionally underrepresented. And it really is, despite decades of supposed attention to this issue or recognition that this would be an important issue both for societal and scientific and economic reasons, we've not made a whole lot of progress. And I think that it is an issue. It is clearly one where we've not clearly reminds one that until you put sort of metrics and accountability into place, you're not going to change something. And we're still in the process of compiling our final report. But I will say the thing that is most striking about this is whether you believe getting the right scientific answer is the most important thing, or achieving equitable goals across society is the most important thing, or economic benefits of scientific research is the most important thing. By any of those metrics, the fact that we don't make progress on either women or on historically underrepresented or excluded groups in their inclusion in research, or in making sure that the research represents the distribution of the health burden within the population, it needs to change in order for us to achieve any of those goals.
Great, thank you. I'd like to have another trainee get to ask one of their questions. This one's from Lucia Chen, who has a question for Petra. Lucia is a postdoctoral fellow at Stanford Health Policy.
Hi, I would like to ask Petra and Jeremy the question. Petra just mentioned the people from low income and high income families, they don't have an equal amount of knowledge and equal amount of medical knowledge. And Jeremy has mentioned the quality of education is very important. So do you have any insights into bringing the medical knowledge gaps between people who've grown up in high or low income families? And do you think technology will play a big role in bridging this gap, and how?
Thank you, Lucia, for that very important question. So I think there is extensive evidence of differences in health literacy across the socioeconomic spectrum. One sort of takeaway from my work that suggests that, these differences really matter and translate into health inequality, a narrow interpretation would be to say, okay, it's great to have nurses and doctors, they speak to their own family members and help them, make appropriate health investments. So we should have more nurses and doctors in society. I think that's sort of not the right policy implication, but I think it does suggest that when we craft policies that try to inform, vulnerable populations and give them health information, broad campaigns like putting posters in the subway, get vaccinated might not really do the trick. So there might be something here about, what we see happening inside families, which has to do with trust, for example. So trust in the person that communicates the health information. If someone tells you you should vaccinate your child, it matters a lot, who that person is. Is it someone that you really trust, like a family member, or is it, a poster that you read when you wait for the bus? So I think we should be thinking more about very targeted policies where we try to mimic some of the things that go on inside families. So for example, very, very like health interactions. Suppose everyone, we could have some programs where at the lower end of the income distribution, individuals can, talk to the same provider at this all the time. There's trust being developed. You can, tap into the same person over and over again. So try to mimic this trust relationship with someone within the healthcare system. I think that would be very helpful.
Just to add to Petra's, let me sort of say what I was intending in terms of the comment about education. So if you remember the graph that Petra showed, she essentially showed more or less two parallel gradients where the x-axis was income, decile, I believe, and then the two gradients or set of dots were whether you had somebody with medical background in your family or not. One way to think about that is that the difference in knowledge and or trust, or let's say sort of conveyable medical specific knowledge is what shifts you from the one gradient level to the other gradient level. And to the extent that education leads to sort of that kind of knowledge about health literacy and within a family, that's sort of the direct effect. And the other effect would be to the extent that education leads to higher earnings and therefore going up the deciles of income, then you go up the gradient. And I think what we saw, because that graph went by quickly, is that it may be the case actually that the income effect is actually larger than the direct kind of knowledge difference effect. I don't know, but I was meeting it more in the second term, which is that education leads to greater earnings and that enables you to sort of address and overcome barriers.
Can I just also make one point here? I mean, I think we also want to comment on, we're in a period of like extreme misinformation and disinformation, distrust of experts in this setting. And I think that this is an issue, let me just also say, that doesn't just extend to people of lower educational backgrounds. This extends to all populations, but to the extent we are leading increasingly segregated networks of information, we live in segregated networks of information, the ability to establish trust and deal with the disinformation that is out there will become increasingly difficult. One of the things that you see these efforts on YouTube or Facebook that are trying to get at, vaccine disinformation, and none of those have been done if that disinformation comes in Spanish language, for example, right? So you can already see how we even approach our ways of tackling the issues of trust and disinformation in one very specific way, leaving out large segments of the US population, if we just want to focus there. And I think the issues about trust for people, more marginalized communities that have experienced this major trauma of the pandemic, I think are only reinforcing in bad ways unless we address them in very proactive, sort of positive ways. And I think we're going to be seeing the legacy of that extending into many other sort of health conversations.
Thank you. And I appreciate Petra has answered a couple of the questions that we now don't have time to get to in our panel because we are now at our closing time. So I want to thank each of our panelists for sharing your insights with us, Dr. Maya Rossin-Slater for moderating, and thank you to the audience for your participation. We look forward to engaging with you at future events. As a reminder, a recording of this event will be made available on the Stanford Health Policy website. So goodbye, everyone, from Stanford Health Policy.